Good evening, everyone. Welcome. Thank you so much for your patience as we navigated, as you know, Zoom room technology. Thank you for choosing to spend your evening with us. On behalf of DMPs of Color, we're so glad that you're here with us tonight. I'm Dr. Danielle McCamey, the founder, CEO, and president of DMPs of Color. And joining me as co-moderator is Sarah Najee. Together, we'll be guiding you throughout this conversation. And honestly, this came from our mentorship meeting that we had over a year ago. Sarah and I had the opportunity to connect, and I was so impressed by her and her interest in Black maternal health and her desire to engage further in meeting scholars to understand the expertise and their experiences further. So that brought us here. So, Sarah, please introduce yourself and share a bit about what's going on with you.
Yeah, hi everyone. My name is Sarah. I'm a third year nursing student at Notre Dame, Maryland in Baltimore. And since my freshman year, I've been researching inequities that exist within maternal health care, specifically focusing on the disparity in infant and maternal mortality rates and kind of looking at like how do we close this gap. And that is why tonight is super meaningful because we'll be able to hear about solutions and like how we can advance equity in maternal health care.
Awesome. So thank you, Sarah. We as DMPs of color, we love to create spaces for these types of conversation that our profession needs to have. Not just comfortable ones, but the necessary ones. And tonight is one of those nights. So we're here to talk about Black maternal health, not as a policy brief, not as an abstraction, but as a living, urgent, and unfinished crisis, and one that is claiming so many lives as we speak. But before we introduce our panelists, we want to hold space for two women.
On November 16th, 2025, Mercedes Wells drove to Franciscan Health Crown Point Hospital in Indiana. She was pregnant with her fourth child, and her contractions were around like 10 minutes apart. She waited, she was assessed by a nurse. She never saw a doctor, though. 6 hours later, she was discharged and told to go home. Then, 8 minutes after she and her husband got into their truck, Mercedes gave birth on the side of the road. The video of her labor captured as she was still at that hospital in visible pain, being turned away, it went viral. And in her own words, she said, it was really a horrific situation to be treated like a dog, or not even like a dog, less than. We thought that things have changed at this point in our country, and I don't see a change. Thankfully, Mercedes is alive. Her baby is alive, and because she refused to be silent, a federal bill now bears her name, the Wells Act, which would require hospitals to have a safe discharge labor plan before sending any laboring patient home, mandate clinical justification for discharge, and require racial bias training in labor and delivery and healthcare settings nationwide. Mercedes Wells is not a statistic. She is a mother, a witness, and now she's an agent of change. Tonight, we hold her story and the stories of thousands of Black women whose names as we do not know as the reason we are here.
Dr. Janelle Green Smith was 31 years old, a certified nurse midwife, a doctoral prepared nurse, a newlywed, a daughter, a sister, and on December 26, 2025, 8 weeks ahead of her due date, she became a mother. Her daughter, Eden, was born via C section at the Prisma Health Greenville Memorial Hospital in South Carolina. Dr. Janelle had developed preeclampsia. The birth was early, but she was there. Eden was there. And in the days that followed, Janelle's incision site ruptured. Emergency surgery was attempted and there were complications. And on New Year's Day 2026, 6 days after giving birth, Dr. Janelle Green Smith died. Eden in the NICU while her father is learning to hold his grief alongside his joy. Here's what you need to know about who Dr. Janelle was. She chose midwifery because of us, because of Black women. In her own words, posted on Instagram in 2024, Black women are 3 times more likely to die in pregnancy and in childbirth than any other race. And hearing these alarming statistics, I wanted to do something about it. I wanted to be part of the solution. She was the locked midwife. She stayed with her patients for 10-hour labors. She said, "Look what you made, mama. Look what you did." She treated everybody like humans. She walked into her calling, and she knew the risk she carried. She was nervous, her sister said, because she knew the data. She had spent her career living inside of it, fighting against it for other women, and her worst fear came to pass. The American College of Nurse-Midwives said it plainly that a black midwife and maternal health expert died after giving birth in the United States is both heartbreaking and unacceptable. We do not say Janelle's name to cause despair. We say it because this room, this panel, these providers, this community is exactly what she believed in. She believed the solution was people like you, people who show up, people who learn, and people who refuse to look away. So tonight, do not look away as we begin. Mercedes is alive and fighting for change. Janelle is gone, but her daughter is learning to breathe without her mother in the room. Both of these things are true at the same time, and that is exactly why we are here. Tonight, our panelists will help us see this crisis through 3 interconnected lenses. The first, how silence in clinical settings, unspoken concerns, dismissed voices, miscues becomes a warning sign we can no longer afford to ignore. The second, how the concept of weathering, the physical toll of chronic stress and structural racism shapes what Black mothers experience across their entire reproductive lifespan. And the third, how simulation, AI, and innovation in nursing education are creating new tools to train more equitable, more aware providers. Dr. Janelle believed the solution was us, people who show up, people who learn, and who refuse to look away. And tonight we honor that belief.
And we are honored to have with us tonight 3 extraordinary nurses and scholars who have devoted their careers to exactly this work. So, first, we have Dr. Janet Williams, who is a board certified nurse midwife with over 21 years of practice in municipal midwifery. Having helped bring more than 900 babies earthside, she holds her doctorate from Wilkes University and a master's in midwifery from SUNY downstate. As a fellow of the American College of Nurse-Midwives, a clinical instructor for Columbia's graduate midwifery program, and the CEO of Transitions Women's Health Consulting, Dr. Williams created the signature provider education program, Black Mothers Interrupted, a 5-part framework on implicit bias, racism, and care quality. She is the author of 2 journals for birthing families. Please welcome Dr. J.
Hello, everyone. Thank you for having me today. So I just want to tell you a little bit. My work did not begin with credentials. It began as a young mother navigating a healthcare system that did not make it any space for my voice. I can remember what it feels like to sit in a room and wonder if anyone was truly listening to me. That experience shaped me long before I ever wore a white coat. It shaped how I practice and it shaped how I do clinical care. I believe listening is clinical care, and I believe communication is safety. Through my work, whether developing the Black Mothers Interrupted or conversations nationally, teaching nurses and midwives, advocating on the policy level, My focus remains the same. We have to amplify the lived experiences, interrupt bias, and strengthen systems that care not only for evidence-based, but for equitable care and humane care. So this is why I do what I do, and we have to continue to work hard to make sure that this turns around. Thank you.
Thank you, Dr. J. Now we have Dr. Evelyn Ada Wallace, who holds her doctorate in nursing practice, a master of public health, and is a board-certified women's health nurse practitioner. Her work centers on the intersection of structural racism, reproductive health, and health inequities, with a particular focus on the weathering framework and its implications on for obstetric care. Please welcome Dr. Ada Wallace.
Good evening, everyone. It's an honor to be with you this evening. This is something that is just so deeply ingrained into who I am. My path to becoming an APRN was born out of my own experience giving birth to my first child. And while I have come out on the other side, very much like Dr. Janelle Smith Green, I was inspired to take care of women who look like us because I felt that that was so important. And perhaps my birthing experiences might have been different had I had that experience. And so I have committed myself and my career to taking care of women of color. Mostly for the last 10 years, I have taken care of women in the federally qualified health center space. These are persons who live at the margins, who are most disenfranchised and who feel least heard. And so it really is an honor and a privilege every single day to be able to roll out the red carpet for our fellow women of color, to show them what care looks like, to show them what care they deserve, and to see that health outcomes can be optimal when they are taking care of people who are a reflection of themselves. That shared experience is vital. And I think it's so important that we, as DNPs of color, as nurses of color, are having this conversation one amongst each other, because I think it's going to be so important to be part of the solution. We need each other. So thank you so much. And I look forward to this conversation.
Thank you, Dr. Ada Wallace. Now, last but not least, we have Dr. Candace McLean, who is a director of simulation and artificial intelligence at Monroe University in the Bronx and a practicing family nurse practitioner. With over a decade of experience as a high-risk labor and delivery nurse, she serves on the New York State Maternal Mortality Committee, consults for the National League of Nursing, and travels internationally to train obstetrical teams in best practices for complex care. And her research focuses on simulation, AI, and equitable outcomes for women of color. So please welcome Dr. McLean.
Thank you so much. It's a privilege to hold space with all these people dedicated to addressing maternal mortality and morbidity. So thank you, first of all, for giving me the opportunity to be part of this panel. Just like my fellow colleagues before me, my work stems from personal experience as a young African American growing up in Brooklyn with Caribbean background. Basically, I had my first child in high school as a teenager. And my husband and I to date, he's now 21, but that experience, we always remember it. Being drug tested every week for no reason, right? Being made uncomfortable. When I had to graduate, it was either do I do another year or do I miss a prenatal appointment? So I chose to miss prenatal appointments so I can graduate in 11th grade, which I successfully did. I was one of the five to walk across the stage, but I didn't have the support. I think about the teenagers out there who endured that, my husband coming to class at that time and bringing food for me, but the lack of support from the institution just because I was a teenage adolescent who was pregnant and African American. But look where we are today. So that is why I went into education so that I can give back. It's so important that we realize that people need to see us, people that look like the color of their skin, and that anything is achievable. So being a teenage adolescent parent proudly of it, as he is 21 now and in Hofstra, it is possible, but we need to also continue to hold the torch and create safe spaces for other parents, teenage adolescent Black birthing patients, and Black birthing patients in general.
Whew, we ain't even got started. Y'all giving me chills already. Just the level of excellence. I just already feel it. All right, so let's get into this conversation. Dr. J, We just heard two stories. One of a woman in active labor sent home without ever seeing a doctor, and one of a midwife who knew every risk and still did not survive. In your 21 years of practice, what changes in care models have you personally seen make the biggest difference for Black mothers? And what would it look like if health systems routinely asked, what makes care possible for you?
Thank you, Dr. McKinney. That is such an important question. The biggest differences that I've seen come from care models are designed, the ones that work are the ones that are designed around real lives of people that they're meant to serve. Care can't be effective if we ignore the context. In many communities where I've worked, families are working long hours, they're juggling childcare and relying on public transportation. When prenatal care is only offered during traditional weekday hours, we unintentionally create barriers. And so simply offering evening and weekend appointments can remove a major obstacle for women who otherwise would have to choose between going to work or coming for care, just like Dr. Candace said. One of the most impactful changes that I've witnessed is the mother-baby model, clinic model, when postpartum visits had dropped below 50%, while the pediatric visits were 85% or above. It became clear that moms were basically prioritizing their baby's care over their own. So instead of blaming moms for missing their visits, what we did is we moved the midwife down to the pediatric floor, and we had meetings, and we spoke to the staff there, and we started bringing the mothers in with their babies, and the postpartum visit rate increased exponentially. There was a system, that was the system choosing to adapt and not expecting the women to. So transportation is another critical barrier that I saw when I worked in the Bronx. Many women navigate buses and elevated trains with stairs while they're pregnant, postpartum, post-op, often with toddlers, strollers, diaper bags, and we wonder why they miss their appointments or why they're late. Transportation vouchers or car service would be a really quick fix for that. And they're not conveniences, they are safety interventions. So too often the appointments are assigned without even asking the mother, is it a feasible time for them to come? Women arrive late, and they end up getting blamed instead of someone asking what was their barrier. Did anyone ask them? No. So many women choose between bus fare and groceries, that kind of thing, keeping their job and seeing providers. They have to decide which barriers they can address and which they can't. So when the systems don't listen, women go silent, and the silence does not equal satisfaction nor safety.
Wow, that's amazing. Just something so simple of just asking the question. But I appreciated your comments when you're saying that the systems have to adapt, but also, part of the system is the leadership in those spaces. So thank you for your leadership in recognizing the gap and curating the opportunity for the system to adapt to meet the needs of these moms and babies.
So our next question is going to be for Dr. Ada Wallace and Dr. McLean. So Donnell gave birth by cesarean section. We know Black women experience higher rates of morbidity and mortality, and that cesarean delivery intersects with those disparities in complex ways. So Dr. Ada Wallace and Dr. McLean, what is driving that intersection, and what role does implicit bias play in labor management decisions that lead there?
May I start? So, when we talk about Black maternal morbidity and mortality, I think it's important to understand that cesarean delivery is an important but complicated part of the conversation. Black women in the US, as we know, are 3 to 4 times more likely to die from pregnancy related causes, but they're also more likely to undergo a cesarean section, whether planned or unplanned, compared to women of other races. And that gap is widening. And to be clear, we understand that C-sections are life-saving. They are absolutely necessary. The issue is not the C-sections themselves. The issue is when they are necessary and when they are preventable and how the decisions are made such that patients are receiving them. We know unnecessary C-sections carry risk, right? As we look at Dr. Smith Green, we see increased hemorrhage, infection, thromboembolism, complications for future pregnancies. And since Black women already experience higher rates of severe maternal morbidity, higher C-section exposure only compounds that risk. And so I think it's really important to understand some of the historical context of why this is. So one striking example that I think of how these disparities become embedded into care is the historical use of the race-based correction in the vaginal birth after cesarean calculator, so the VBAC calculator. For years, the VBAC calculator automatically subtracted the predicted success rate for women who identify as African American or Hispanic. So simply by identifying as a Black woman or Hispanic woman, you have points subtracted as to the success or the probability, the likelihood of a successful VBAC, right? Not looking at age, not looking at BMI, not looking at obstetric history as factors that are traditionally going to be an indicator of success, but race. And the problem is that race is not a biological mechanism of labor. And so this is where we have biases that are not so much implicit, but that are ingrained into the healthcare system that are impacting women of color who are delivering their babies. And I think that's something that we have to reckon with. We have to understand the historical context there and recognize the impact that it's had on so many birthing individuals. I'll pass the torch to Dr. McLean.
No, and I just love that you mentioned that, Dr. Wallace, especially about the VBAC calculator. As myself, I am a C-section mom 3 times, and then comes 2017, I had my first vaginal birth after cesarean, right? I am not your typical candidate. I was always told going into these physicians' offices and even using racially concordant care, I was told, oh, your BMI is too high, you won't be successful. As a provider and a person out there in healthcare, we will listen to our caregivers. We want to be safe. So if we're being told that we won't be successful, we won't. And if we're being shown a calculator, which was just revised in 2021, and my births were in 2005, 2007, and 2009, that was a different era, right? So now, fast forward to 2017, when I had my first vaginal birth, I wondered, can I be successful? And we really need to get this campaign out there that Black women do VBAC. And we need to eradicate the fact that there is any difference. There is no genetical racial basis that we cannot be successful birthing. We just need to be given the opportunity. And I think consistently we're not being heard. And all these stories, whether it's the Kira Johnson all the way in California, the recent Green story, Black women are not being heard, right? In New Jersey, they published an article, Doctors Give Black Women Unneeded C-Sections. One of my pet peeves about this article was we know the data. We know it's attributed to systemic and structural racism. And we have the facts that it shows that if you're in New Jersey, irregardless of your education, you're 25% more predisposed to have a C-section just because you're African American race. But where's the gap, right? Because we have all that data, but we're not doing anything. Hence, as we say in Spanish, it's basura. It's garbage. Because now we need to hold accountability. So what are we doing to these providers that we notice high tendencies to have C-sections for their Black and brown patients? There's nothing being done. They can go and practice in New York, they can practice in New Jersey, and still continue to have these rates. We need to have bigger conversations of policies, insurance reimbursement that address this behavior, or it will continue on this trajectory that we're going to have alarming C-section rates. I do want to bring attention, if you don't on this call, to the book Legacy. And I know due to the blur, you're unable to see it, but it's Legacy by Eustace Blackstock. And there's a part in it, and I want to read it really quick. Beyonce is a world-class singer and performer. Serena is one of the greatest athletes of all time. Both women are healthy, incredibly fit, and know their bodies well. Beyonce experienced the same pregnancy complications as other Black women with considerably fewer resources. Even with my 2 Harvard degrees, I have a pregnancy-related mortality ratio 5 times that of a white woman who never finished high school. We need to address these statistics, not just by keep republishing them, but now we need to hold providers and institutions that have disproportional rates of C-section rates for Black women accountable. Thank you.
Well said. I kind of want to unpack and dig into what does accountability look like? Because I know when we have these type of discussions, we talk about structural racism, we talk about implicit bias, we talk about provider behaviors. So, what are some thoughts from you all, from your perspective, on what those accountability measures look like?
I think it's multifaceted. I think, first of all, we have to call it out, right? I think just as Dr. McLean said, we can't just keep talking about the statistics. We have to really be talking about the fact that this is something that we understand. We have the statistics, but what role do each of us play? And I think we have to take the conversation out of interpersonal relationships, and it has to come from an organizational level, a higher policy level. And I think that's where I think we're halted. I am inspired by the fact that Black maternal morbidity and mortality is a very big conversation piece. Now it is getting the lens, perhaps because of the Beyoncés of the world, perhaps because Janelle Smith Green died in such an insidious way that it didn't need to be, that we are now having the conversation. But this has to be a policy level. We need to be bringing this to our C-suite. And there need to be far more than just trainings. There needs to be, I think, a change in the ways in which we're educating, which is why I have pivoted from full-time clinical practice to full-time education, because I feel that, okay, I've done the work. I know what needs to be done. Now we need to educate the next generation of providers, and they can't just always look like us. I feel like we hold each other accountable so much. You know, Dr. McLean, I want to see you doing this. Dr. Williams, I want to see you doing this, but you're doing it.
Yeah.
I think what we really need to do is call to the carpet those providers who do not look like us.
Mhm.
And we need to be having these conversations far more frankly. And we need to be asking them, what do you plan to do? I think the accountability needs to be reversed as opposed to the burden always being on us. We are always going to be on the diversity, equity, inclusion panels, right? Those of us in this room. But I think we need to bring others in the room because I think that's where there's a gap in the conversation.
I basically started the Black Mothers Interrupted Framework because I worked with many medical students who were coming from the Midwest. They had never even seen Black people until
That's right.
they came to New York. So how do we expect them to even understand? They just knew what they knew. They had their biases from their immediate surroundings, from their families. They were like little innocent people. When I would look in their eyes, I said, this is not somebody that has thought about this. This is total implicit bias, that this is just how they were raised. And so that's where Black Mothers Interrupted came into play. I started with a group of them around the table after grand rounds, and we talked about bias, what it is, and that all of us are biased, and talked about the different types of bias and how it affects on different levels. I talked about board report, and I gave them examples at board report, different information that was given at board report, and how that's biased, and how when now you've heard that report, you walk in the room, you treat that patient in a different manner just because of what you heard, or you read a chart and the documentation, it says non-compliant, or it said something that made you already put that patient into a category. So definitely education for everyone is so important.
Absolutely.
I agree, Dr. Williams, so much with your thoughts, but maybe I'm a little bit too aggressive. I also want financial accountability
Oh,
for us.
absolutely.
I want to see that if they keep having reoccurrent C-sections at alarming rates, they have to pay a fine. And I feel like when I notice the change will come is because of that financial obligation. Morally, should it be done? Of course. But then to hold them to it, I think we need to hold a financial stipend. Whereas if we keep seeing that your facility is having significantly high rates, that you do pay a penalty because it's disproportionate, right? We have NTSV rates, and for those on the call who do not know, nulliparous, term, singleton, and vertex. Those are the rates for our first-time moms that we should be looking at. Irregardless, even in New York State, and when I was looking at the data, it always hurts my heart to think that at least 72% of women, their first time will be sectioned in New York State. That's alarmingly high. And once you have that trajectory, as I shared myself as an example, you continue on that C-section journey because the providers are scared they're going to cause more harm to your uterus. So we really have to think about holding them accountable because it's affecting our reproduction in a whole for Black and Brown patients if we don't. And we continue in this manner where people are not being held accountable in the facility and they're at higher risk.
I agree.
I love it. And Joan, we'll get to your question. We have like two more sets of questions, so please feel free to post it in the chat. But in the words of Dr. Monica McLemore, because we can't be talking about this topic without mentioning Dr. Monica
Yeah,
McLemore. If you can't legislate, litigate.
that's
So
right.
start coming
That's
for
right.
people's licenses, reporting to regulatory bodies. And then in that litigation come and get that check. But obviously I'm making light of it, but people's lives are being impacted. I mean, life altering. And so I appreciate all the accountability measures that you all called out. And I think that it's incredibly important to bring out that the accountability piece beyond the conversations is critically important. So thank you for offering that. And so I do want to get in a little bit on the two topics. One is weathering, and then we'll transition to some of the AI stuff because I'm so intrigued to hear more about your work in that space, Dr. McLean. But Dr. Ada Wallace, so I just wanted to, because I think it's important to bring out this conversation. Um, Dr. Janelle Green Smith was a doctorally prepared nurse midwife who knew the data better than most, and still developed these hosts of complications after her C-section. And so I wanted to bring in the concept of weathering because I feel like it's important to elevate that because it's part of the conversation. When we talk about weathering, are we talking about something that even knowledge and professional status can protect against? So if you could help us understand what weathering actually does to the body and ways that we could strategize to assess the risk for it.
Wonderful question. Thank you for that. So, weathering is something that I'm very passionate about because I think it explains so much of what we see in the healthcare landscape as it pertains to women of color. So, when we're talking about weathering, we're talking about the idea that racism is not just a social issue, but it becomes a biological one. And the concept was introduced by a public health researcher who I revere, Dr. Arlene Geronimus, who described how this chronic exposure to racism and structural inequity is going to lead to premature biological aging, especially in Black women. So, in other words, the body weathers under constant stress. So, it's not about one bad day. It's not about one difficult pregnancy, but it's about years and often decades of navigating discrimination, economic inequity, neighborhood stress, safety concerns, barriers to care, and I can go on. And that chronic stress activates the body's stress response system over and over again. And over time, we get something called an allostatic load. And that's the cumulative wear and tear on the body. And we can really measure it in biomarkers like blood pressure, cortisol levels, other inflammatory markers. So by the time a healthy, educated, middle or upper class Black woman becomes pregnant, her body may already be carrying this physiologic burden of chronic stress. So that helps to explain why we see some disparities in maternal morbidity and mortality, even when we control for income and education. Weathering often reminds us that Black maternal health outcomes are not about just individual choices. And I really want to make sure that we remove that conversation because I feel like there's so much blame and onus on the individual birthing person. And that bothers me tremendously. But instead, it's really about that cumulative exposure to the structural conditions that we understand our communities to be exposed to. So we have to widen the lens. And when we widen the lens, we see how, of course, history shapes biology. When we talk about redlining, we talk about the GI Bill that excludes many Black families. We talk about segregation, mass incarceration. These are just minor footnotes in history, minor footnotes, but they shaped housing. They shape wealth accumulation. They shape neighborhood resources, access to healthy food, safety, quality health care. And these structural forces are what shape the social conditions that our patients live in today. And so when you layer on intersectionality, race, gender, and class, Black women experience this unique convergence of stress that directly affects pregnancy outcomes.
Yeah.
That part, like, I mean, even before we even get to having the opportunity to be pregnant and then birthing, all of that extra layer. Whew, thank you for elevating that. I think that was important to mention. So I'll pass the mic to Sarah.
All right, thank you. So our next question is going to be for Dr. McLean. So Dr. Janelle Greensmith, she called, as Dr. McCamey told us, she called herself the locked midwife. She said she wanted to be the change. She used her skills, her presence, her identity to close the gap, one birth at a time. And so as we think about what simulation and AI can offer, how do we like build our systems to be robust enough that, the burden of change isn't carried solely by Black providers who enter the room and make themselves the intervention?
Sarah, that is such a wonderful question because that is how I use simulation as a teaching pedagogy so that we can bring to highlight these scenarios and these DEI scenarios that people are not uncomfortable with always. I do two types of simulation. I do high fidelity in person, and then I also do virtual reality. I just want to speak about the virtual reality real quick because in collaboration with health scholars, we embedded Black avatars. It was very important for me to carry this charge, for you to have a conversation with the person in the room when you're doing stuff to their wife and their significant other. So in the clinical scenario of the virtual reality, the patient is having a hemorrhage and then they have to mobilize to the OR because it reaches an excessive quantitative blood loss. The partner, you will not proceed to the second stage until you tell the partner, hey, your wife is hemorrhaging, we're concerned, and we need to mobilize to the OR for a closer visual. Or you have to say something to that extent. But the importance of it was including the partner. So much feedback when you speak to these partners who survived maternal mortality, such as Charles Johnson and Jose Perez with the recent event at New York City Health and Hospitals, the feedback was not feeling respected, not having communication, even though in the height of it, they were losing a loved one. So that's important to me that we incorporate that in simulation, fostering communication. One of the things we need to do is not do negative reinforcement. There's already an ideology about how Black people show up in a hospital space. We have to be very careful not to foster that we're aggressive or non-communicative, right? So we need to make sure that our simulations reflect this. One of the things I always teach people in obstetrical simulation, something common is that you'll see they'll do a placenta abruption with an African American woman who took cocaine. We need to eradicate things like that. That is not acceptable. And not every African American woman who endures a placenta abruption is due to cocaine. One of the number one causes that are non-obstetrical is due to a motor vehicle accident. So using your scenarios not to foster negative stereotypes can help to reduce implicit bias. And even when it does come up in debriefing, you want to have a conversation about where did that come from? Where did it stem from? I remember one scenario in which the patient had sickle cell. I created this scenario because I wanted them to do pain in the obstetrical birthing patient who's African American. And they would not give this woman pain medication. They didn't consult, and it was a big topic in the back in the end conversation. She was labeled a drug seeker, even though it was showing her reticulocytes were significantly impacted, her RBCs were being affected. She was in a sickle cell crisis, and yet they didn't want to give pain. So this is conversation. Was it implicit bias? Was it that they were scared that she's drug seeking? But to have those conversations when you create simulation scenarios are important. And that's what we need to do, whether we're teaching in a hospital setting or our students, to show them that whatever we do, it's not to foster biases against our population or race.
Wow. Awesome. Thank you so much. And then I think it's critically important to be thinking expansively about the simulations and the bias that are inherently in some of those. So thank you for sharing some of the innovative solutions that you're coming up with around that education, because that's where the seeds are planted in the schoolhouse. So we do want to open up for Q&A, and Joan threw her hand up like, look, I got a question. So Joan, we looking at you to go ahead, either unmute or put your question in the chat for our panelists.
Good evening, everyone. First of all, thank you so much for holding this. This is definitely a critical and important conversation, and I'm just honored to be able to attend and listen in. My name is Joanne, and I'm from Brooklyn, New York. And Dr. McLean, you had mentioned financial accountability regarding the C-section rates. And I just wanted to mention, I had in December of 2022, I had the opportunity to go to UAE as an A1 delegate and meet with the Ministry of Health and visit different hospitals. And in one of the public hospitals, one thing I loved that they did, the way the physicians held each other accountable was they would actually have a board on the floor and would post their statistics, like their numbers of C-sections, the number of vaginal births, and that's how they would hold each other accountable. So I'm just thinking now, just, it's coming back to me, like maybe if we can implement something like that in our institutions, just to get the ball rolling. But I definitely agree with the financial accountability part. I have more things in my mind, but I'll let anyone else ask the question. But I just wanted to bring that up. And I don't know if anyone wants to speak to that.
No, thank you, Joan, so much. And definitely, I want to get it heavy hitting because I just find we're only speaking and that there's no solution. So I feel like if we have financial, like if we know, just calling out systems in New York, say New York Presbyterian has a 10% rate, and that's the standard, and that's considered well. But then we go over to New York City Health and Hospitals, and it's 40%. We need to do something to get them back down to what is the standard. But there's nothing in place right now that's a metric that says, hey, this is a dangerous hospital. Even with the Earth app, and I love the Earth app, it's an amazing app, and I highly recommend it for anybody birthing. But at the same time, what is being done with the data that comes from it? Right? You hear about, hey, this provider is concerning or this institution is concerning, but where is the accountability for it? They're still getting compensated and they're still in business. When we don't like something, we put it out of business, right? When Target left DEI, we tanked it. We stuck together. So I think there just needs to be more accountable. And I feel like a financial aspect would be a way to be successful there.
Dr. McLean, I think you raised such an interesting point, and there is somewhat of a precedent for that. If you look at the health systems, right, they get financial dollars if they're meeting certain metrics. If you have high breast cancer screening rates, if you have high colorectal cancer screening rates, if you have low infection rates, they are incentivized financially. I think it needs to be flipped in that same regard that if you have high C-section rates, and I think it would be important to also stratify that data. Let's have some data transparency on the outcomes by race, right? Because I'm sure we will see those variances. I think it's important to withhold that money because that would probably be an incentive for them to get their acts together. Because, like you said, I mean, there's the fine component, but also withholding money. That's gonna make people start to think. That's gonna make the C-suite start to say, well, now we need to make some changes. So I think you raise a very interesting point, and I think we have to get innovative in the ways in which we come up with these solutions. Because, like I said, we can't do it at this interpersonal level. We need something that's a policy level. We need something more upstream. The health systems must move upstream to make these changes. And we need something much more standardized and much more punitive in order to see these changes happen.
Dr. J, did you have any thoughts?
I just feel that we also are looking at a lot of statistics, which are just numbers, and we need to be looking at the lived experiences of women. And unfortunately, they are not measuring that yet. Okay, Dr. Karen Scott, if we could use her platform, that would be awesome. We need to see women that are discharged. They look at, if a mom and baby go home, they look at that as success. But you have to look past that. You have to say, what was the experience like? How did that family go home? Were they traumatized? Was it, was it just okay? Did they have morbidity and they got over it? You don't know. You just know they went home. We need to hear the lived experiences of the families that are being cared for.
I love you, Dr. J, because you always bring it back to the to the humanity and the people centric of the whole situation. So thank you for being consistent with your messaging. We do have a question in the chat from Rachel. She wants to know, how do we begin to approach applying the accountability discussed earlier in areas where there are significantly less medical clinicians of color? Also, I have enjoyed listening today. Thank you so much for your time. I just entered my 20s as a Black woman, so it means so much to hear and see so much passion and effort being put into fix one of the many parts of the system that have ignored our needs for so long.
So what I will say is that the ways in which that I felt very compelled to change or move the needle was to go into education. I think we need to bring our counterparts into the conversation. And I think we have to train up the next generation of clinicians. Accountability shows up in lots of different ways. This is not a single pronged approach, it's a multi-pronged approach, right? We need to be having these conversations, but I think we need to bring multiple people into the healthcare landscape so that they can see at the level of being a student what it looks like to see a Janelle Smith Green, what it looks like to have a Kira Johnson as your patient, and to see that you took care of them and they didn't come out on the other side because of a decision that you made. And so it's really difficult. Accountability shows up in a lot of different ways, but I do feel that, at least from my immediate perspective, that I have felt that I have done really well as a clinician. And now I want to move that forward and help with accountability so that our other clinicians are doing the same thing.
I
Awesome.
also just would like to say that I look at it also from a policy standpoint. I know many hospitals, if you're 20 minutes late, half an hour late, you're rescheduled. And I've seen things happen where patients got there late and the desk clerk basically rescheduled them because that was the policy. And I had a patient that went home. She was never seen by a clinician. We didn't even know that she had arrived. And she was sent home and 2 days later came back by ambulance after an eclamptic seizure. That's the kind of stuff that needs to change. So some of these policies and procedures that are in place need to change. So from a policy level, that's a big part of it.
Amazing. And we're getting close to time. I wanted to see if we have room for one more audience question. So Pamela, go ahead and unmute and we want to hear your voice with your question.
Thank you so much. I'll come on camera as well. Good evening, everybody. I'm Pamela Davis. I'm with the National Council of Negro Women, the Queens County section. Hi, Dr. Candace McLean. Good to see you. Dr. Janet Williams. Good to see you as well. I'm the Maternal and Child Health Committee Chairperson for NCNW. So my question was centered on how do we share best practices with, excuse me, Black women and birthing people, their partners and families to help them advocate as they are navigating the maternal healthcare system. We're planning, excuse me, we're planning an event for Black Maternal Health Week coming up in April. And so I wanted to make sure that a portion of our program is also dedicated to community empowerment, right? As they're navigating through that healthcare system, oftentimes when they encounter providers, it's like whatever the provider says goes, and they're afraid to ask questions. And so we're hoping that a part of that program can be devoted to giving them some tools and strategies that they can use in real time as they're navigating through the healthcare system. So I was wondering if any of our panelists have any strategies that can be shared. Thank you so much.
May I?
I would like, oh,
Go ahead.
Oh no, you go first. You were before me.
no problem. And that's such a great question, right? Because we need to empower people to be successful. I always like to tell Black and Brown birthing families, I highly recommend a doula. That is something that was unique. People like to associate it with the Jewish Orthodox population, and it's not, right? We need to all be protective of birthing. So it needs to translate more into the Black and Brown birthing communities. Doulas do not guarantee a safe delivery, but they can help navigate the questions, the concerns. Do I get my membrane stripped? How do I feel about this choice? Do I want a Foley balloon, a cervical balloon? Do I want to get induced? Because the medical terminology, the patients just do not know unless they themselves are in medical field. But the doula has insight, so I really highly recommend that. Having a doula faction at your community event is so important. One of my best spaces for sexual reproduction conversations about UTIs and managing bacterial vaginosis, you know where it transpires at? In the hair salon. When I hear a woman talking or something, and I just politely say, hey, I'm a GYN provider, I heard you were talking about BV. And you would be amazed how comfortable everybody in that space. We need to get out in the community, hair salons, nail salons, places where Black and Brown patients frequent. But since they're coming to you at this front, Bring the people to you. Invite hairdressers, invite your community barbershop because that's where your population is.
So if I can just add to that, because I think that's a fantastic point. I get asked the question all the time from my patients, from my friends, from family, how can pregnant patients advocate for themselves more? And I always want to answer that question carefully because while self-advocacy is powerful, I feel like it shouldn't be the responsibility of the pregnant person to overcome those systemic inequities on their own. That's so overwhelming. That said, right, there are ways that I think patients can feel more empowered in their prenatal care, their labor, their postpartum. And I think we as clinicians should actively invite that empowerment. So, first, pregnant people should feel empowered to ask, what are my options? If a clinician says that a test, an induction, a C-section, a medication is recommended, it is completely appropriate to ask, what happens if we wait? What are the risks if I do this? What are the benefits? What are the alternatives? That's not being difficult, that's being informed.
Right.
And I think we have to empower our patients to ask those questions. I also think it's important for people to feel comfortable saying something doesn't feel right. I always tell my patients, no one knows your body better than you, right? And so we know that many severe maternal complications begin with really subtle symptoms, that headache, that chest pain, that's vision change. And it's often very common to explain it away. But if a patient says something feels off, they deserve that dignity and that evaluation and not dismissal. And so I always empower my patients, if you feel the slightest itch especially while you are pregnant, call me, come in, because I would rather it be nothing than it be something that was dismissed and taken under the table. And just in the interest of time, I'm going to leave my comment at that.
Thank you so much. And
Thank you
so,
both.
yes, in the interest of time, Joan, we see you, but we're going to have to wrap up. One thing about me, I like to start on time and end on time. So, feel free to email us and we can share the question amongst the panelists. But I will pass the mic to Sarah for one final reflection.
Yes, so before we close, we'd like to ask each panelist, what is one message, one thing, your call to action for every person watching tonight, what you want them to carry with them from this conversation?
I guess I'll go first. Um, we've named a lot of disparities here tonight. And what I say is that naming disparities without implementing change is just performative. Families deserve to know what will change. They need to know who's going to be responsible for the change and when those changes will be implemented. Equity work without timelines is not strategy, it's just a delay. So at this point, I'm so happy that we were able to be together tonight, but we have a lot of work to do, and I think people need to be held accountable.
I will just add, I'm so hopeful that, this conversation is being elevated in the way that it is and that it is getting attention. And I think community voices are being centered more than ever before. Black women and midwives and doulas and patient advocates are shaping policy conversations and ultimately hospital protocols. So we are moving from being performative to actually building and changing with our communities in hand.
Thank you, Dr. Wallace. That was so good. I would just like to end and say nursing is a calling, but maternal care is a special calling. And we all choose to walk in this. And no patient ever walks into the facility, even when they don't feel the baby move or have a history of a stillbirth, they do not expect to walk out without a baby. I just want us to be cautious of that and know our duty is as a nurse to always be empathetic, but to actually show it to our patients. Sometimes I feel like we don't let go of that. And we have to be particularly mindful of right now political temperament, how it's impacting our patients who are not in the North. The South is going through a lot of reproductive changes. The reversal of Dobbs versus Jackson, which reversed Roe versus Wade. We see a lot of those patients now coming to seek termination resources up here, and they're late. We do not judge whether they're 28 weeks because they couldn't get access. And that's the harsh reality right now of the political temperament. And we're not going to get into it. It's not about sides, but it's about the injustices being done to the populations, our transgender. And we need to be mindful of everything that's being done within this current phase, how it will impact us in 4 years when it changes again, but we don't need our patients to feel it. So I want us to carry that torch and be the greatest advocate because more than ever, as Dr. Williams and Dr. Wallace said, we need to know there's a lot of work to be done, but it's going to be harder than ever. But our patients are counting on us because no one's intention is ever to walk out without their babies. And we know Black and brown birthing women are at 8 times their risk.
And what a perfect message to end the night on. We thank you to our panelists. If everyone can give a virtual hand clap for their expertise, their advocacy, and most importantly, their time in this work. Thank you all for spending the evening with us. There is a link in the chat to a survey so that you can get 1 CE for spending your time with us this evening. Thank you so much. And we hope that you have a great rest of your night.